It's now my pleasure to introduce Professor Rob Newton, an accredited exercise physiologist from Edith Cowan University, so thank you for travelling so far. He leads world-leading research on the benefits of exercise, and he's going to talk about exercise now. Please make him welcome.
Good morning, thank you very much. Can everyone stand up, please, for a moment? Everyone up. The quicker you get up, the better, okay? So what we're going to do is just going to go down and up. 1, 2, doesn't that feel great? 3, 4, there we go. We'd like to do more. I've got lots to say, so we don't have more time. But please sit down. Congratulations, you have just increased your insulin responsiveness, your blood glucose is more normal, and your brain is starting to feel some really nice drugs from exercise. So I've been asked to talk about our research into exercise medicine and its value in prostate cancer. So why do we talk now about exercise as an actual medicine? Well, it's because when we exercise, our body produces a very large range, in fact thousands of drugs within our body which are produced. Predominantly they pour out of our muscles, but also out of our adrenal glands and a whole range of other endocrine glands within our body. So our body's producing its own medicine. Exercise also derives direct structural repair and adaptation in our body. In particular, it helps us to make our fat cells smaller and our muscle cells larger, which is also very important. We also see that it produces vascular adaptations and increases perfusion through our tissues, including through prostate cancer. Very important, we'll come back to this as an important role because we'll also talk about how exercise actually facilitates other therapies and also reduces the side effects of the common cancer treatments. So we'll talk just a couple of definitions first. The first one is aerobic exercise, which you'll be more familiar with. This is large muscle groups, activities like walking, jogging, cycling, rowing, swimming, whatever you'd like, dancing. It really needs to be of moderate intensity, not low intensity. We're trying to produce quite a strong disturbance to the homeostasis of the body. We need to create that disturbance so it produces this internal medicine to help us to fight the cancer. So very light exercise is of benefit psychologically, but physiologically it doesn't have the same benefit as more moderate or even vigorous exercise, and we'll see some interesting survival data around that. But we can do what is called moderate intensity continuous, so that's when you just go out and you swim for 20 minutes or you do a brisk walk for 20-30 minutes. Or it can be high intensity interval training. That's where you alternate periods of high intensity effort where you go pretty much flat out for perhaps 60 seconds or up to 4 minutes, and then you have a active recovery where you bring the intensity down. Now that's also very important because it creates different hormonal changes within the body, which again produces different medicine within the body. The next type of exercise, which is very, very important, and it is definitely underutilised and quite often neglected, but we are meant as a species to lift heavy things. We have evolved over 45,000 years or more to actually lift heavy things every single day. So it's very important for us to continue that. So resistance training means lifting weights. In general, it can be body weight or it can be within machines, but the weight has to be heavy enough so that you can only do between 6 and 12 repetitions. If you can do 30 repetitions, it's not resistance training. It doesn't, again, produce the same stimulus on our body to help us to fight the cancer. Okay, so this is a study from way back in 2011 by colleagues of ours, Ken Field and others, University of California, San Francisco. And this was one of the first studies to come out showing a relationship between the amount of physical activity that men with prostate cancer performed and their actual survival. And what they reported was that men that did 3 or more hours per week of vigorous activity had a 49%, say 50%, let's round it up, 50% lower risk of all-cause mortality. Well, we know that. If you're physically active, you're less likely to die of anything, right? That is nothing new. However, they had a 61% lower risk of prostate cancer-specific death. Now, this was very important. That's a huge reduction in risk, but also the fact that it required vigorous activity. Not too much, though. I mean, 3 hours per week, Okay, that's not a lot of physical activity. What we've also found is that the responsiveness to exercise is highly specific in cancer patients. Now, this is a particular study here whereby these are men with prostate cancer. They're on androgen deprivation therapy, the majority of which will have received radiation therapy as well. And the problem, whilst androgen deprivation therapy that many of you will be experienced with, is that whilst highly effective for slowing progression of the disease, it has considerable side effects. Not the least of which is an increase in metabolic syndrome, cardiovascular risk, heart attack, stroke. But also we see a devastating loss of muscle mass, an increase in fat mass, and a loss of bone density, which can be quite catastrophic for the patient. In this particular study, we actually was published last year in Medicine and Science, Sport and Exercise. We had patients who are on a delayed treatment, so usual care here, and then we had a group that did a combination of aerobic exercise and resistance exercise, which you've seen. So this group here was lifting heavy weights, and this is the change in their lumbar bone mineral density over 6 in the darker bar and 12 in the lighter bar months. What do we see? No effect of exercise, no benefit. If we were to give this intervention, combination of resistance training and aerobic exercise to, say, postmenopausal women, we would have seen that they would have totally blocked that loss of bone. But in men on ADT, it doesn't work. It's the wrong medicine. It is insufficient. It was only this group here did a combination of resistance exercise, so lifting weights, but they also did this impact loading. This patient is 72 at the time of this recording, and he is a man with prostate cancer and androgen deprivation therapy. Okay, so I don't want you at lunchtime everyone to race out and start bounding down Burke Street, is it, I think, outside? Okay, these men underwent 3 months of conditioning, resistance training to make them strong enough and their connective tissue resilient enough that they could perform this type of very high-intensity impact loading. Why would you do it? Because it pretty much blocked the loss of bone in these men. So this was a world first to actually show that exercise medicine could prevent bone loss in men on androgen deprivation therapy. A very important outcome. But you have to use the right medicine. All exercise is beneficial, but as you'll see, we have to use targeted exercise if we really want to address the issues which are most likely going to affect the patient. I'll skip over that one. So, wow, we're seeing that if you are physically active, that you actually live longer with your disease. That's astounding. How? Why? It's not just the fact that when you exercise, it reduces your cardiovascular risk, your diabetes risk, etc. We're also seeing that exercise suppresses the progression of the tumour itself. This has been well established in a wide range of animal studies and is now increasingly being proven in human trials. So in 2016, we published a paper in the Nature Reviews Urology where we proposed 10 mechanisms by which exercise medicine directly impacts tumour progression. We don't have time today to go through all of them, but some of the key ones here is that exercise is a great promoter of immune function. Now, the very exciting area at the moment, of course, is immunotherapy. Not well applied in prostate cancer at the moment, but certainly having great effect in non-solid tumours like leukemia and also in lung cancer. All that therapy is doing, well, not all, it's fantastic, is it's actually switching the body's own internal immune system on, ramping it up, making it more robust, and the body's own defences attack the tumour. Exercise does the same thing, as we'll see in a later slide. Some other changes, of course, as well, is reduced inflammation, systemic inflammation in the body as well. Better regulation of certain hormones, for example, insulin in particular. For patients that have poor insulin control, they might be diabetic, for example. This is a problem because glucose feeds the tumour. Cancer cells can only use glucose as an energy source. And so in a high level of glucose in the blood, that's problematic. Exercise helps to normalise that and reduce those effects. There's an interesting study here. This was done in 10 male individuals And these were healthy young men, okay? They did not have prostate cancer. And they did 60 minutes of cycling. And then the researchers took their blood before they cycled and then immediately afterwards. And then they took prostate cancer cell lines. So these are actual live prostate cancer cells, human prostate cancer cells, in a tissue bath. And they actually poured the serum that they extracted over the prostate cancer cell lines. And what they saw is 9 out of 10 individuals, they saw growth inhibition. When they pooled the exercise serum, they had 31% overall inhibition of growth. So this is the data here. This is in black here. This is a inert, just a solution here. This is at rest. So this is the serum that was extracted from these people before they exercised. There's no effect. So these anti-tumour substances or medicines are not circulating in the body at rest. It was only the post-exercise serum that produced this 31% reduction in the rate of growth. So when we exercise, there are literally hundreds of substances produced in the body which have a strong anti-cancer benefit. This is a study which was conducted in rodents this time, and it does illustrate a very, very important point about the effect of the exercise on in terms of immune response. Now, this was, they took 12 rodents, little rats, mice, and what they did was these mice were genetically identical. So they were specially bred, so they are absolutely identical. They were in the same room. They were kept in the same lab, in the same 12 cages. They were fed the exact same diet. The only difference was that 6 of the rats, in their cages, they put a running wheel. Now, rats, if you put a running wheel in, they'll run most of the night. So rodents are predominantly nocturnal. So they'll run. They'll hop off, have something to eat. They'll hop back on. They'll run. And they'll do many kilometres in a night. They'll run most of the night. And what they found was they injected, before they started the study, they injected the animals with human melanoma cells. And melanoma cells generally develop in the lungs. And when they looked at this is the difference. This is the animals that were the control, that didn't have access to a running wheel, and these were the exercising animals. Massive difference in terms of tumour volume, and also the number of lung tumours here as well. So these are the poor little rats after they sacrificed them. This is their lungs. And you see here the lungs of the 6 control animals, and all of this black tissue here is the actual melanoma cancer. And this is the exercising animals. So the exercise has a massive suppressive effect on the actual progression and growth of cancer cells. I'm supposed to have another slide there. I better talk to it, eh? How does this happen? Well, the way in which it happens is that what they found when they sacrificed those animals was that the lungs were absolutely filled with natural killer cells. Natural killer cells are one of the most aggressive and powerful cells within our body that actually will go around and find tumour cells and actually attack and destroy them. And exercise caused a greatly increased activation of natural killer cells and made them more hypervigilant. They were more effective at actually finding tumour, cancer cells, and destroying them. So that seems to be a very important effect there of exercise. Now, this slide's very, very busy, and I do apologise for that, but it's a nice summary of some of the other mechanisms that are occurring here when we exercise. So when we're sedentary, we have a bit of a problem here. We're not using our muscles. We're spending a lot of the day seated, and we've got an environment within our body in which we have increased metabolic problems, so insulin is higher, glucose is higher, another hormone called IGF-1 is increased. All of these factors tend to feed tumour development. Particularly in women, if they're sedentary, then they have high levels of the sex hormone estrogen. And this, of course, in breast cancer is a very strong driver for breast cancer development in women who have that responsive type of breast cancer. Inflammation is higher. IL-6 and what is called C-reactive protein. These are pro-inflammatory molecules. Again, this status of being sedentary, high levels of inflammation is very promoting of cancer development. However, if we exercise acutely, our respiration goes up, heart output goes up, and this creates increased perfusion through the tumour, greater oxygen being delivered to the tumour as well. We'll see why this is important. Increases in adrenaline, which also has a very important factor in terms of immuno responses as well. This reduces hypoxia within the tumour, and we'll see in a moment as to why that's so important. But then if we exercise repeated bouts here, each time we exercise, we're giving another dose of medicine to the system with this anti-cancer effects. We also start to change our body composition. We increase our muscle mass and reduce our fat mass. This is very important because it's strongly linked to our response, for example, to chemotherapy and the side effects that we have with chemotherapy. Having low fat mass and high muscle mass is very, very important in terms of patient outcome. So exercise seems to be working from 2 points of view. It reduces treatment toxicities and it increases therapy efficiency. So it's said to increase the size of what's called the therapeutic window. So this graph here is the actual response to the intervention, the therapy, whether it be chemotherapy, androgen deprivation therapy. And this is the treatment dose. So with increasing dose, you tend to have a much better response here as well. But the problem is you also have increasing toxicities and side effects. What exercise does is it shifts the toxicity curve to the right, so you have less side effects, and it shifts the efficacy curve to the left. So lower dosage of treatment has a higher effectiveness in terms of killing cancer cells. The result is the therapeutic window shifts from this wide out to here. So you have a much larger scope to be effective in terms of treatment. This repeat bout effect is very important. We see here when we exercise that we have these spikes that occur in our body. So every time, even when you did those 4 squats, your body started responding. Your heart rate went up, your blood pressure went up, that pushed more blood through your various tissues, a whole lot of hormones responded. Not a big response to only 4 squats, but as you can imagine, a 20-minute high-intensity effort is going to produce an incredible mixture of chemicals to be released into your body, of medicines. And so this is what's happening here. You're reducing a lot of these substances as you exercise, and then as you recover, they settle back down to rest. But then you exercise again a couple of days later, and then a few more days later. And each time you're actually injecting anti-cancer drugs into your body. So, the important message from this is it is probably likely to be more effective to exercise on every single day for a small amount. So you get a dosage of these anti-cancer drugs each day. So, analogy is that's better than, for example, going out and running a marathon on a Sunday for 4 hours, okay, and that's your exercise for the week. It would be better to spread it out. So that'd be the same as if you have back pain, you don't take the whole bottle of Panadol on a Saturday, okay? You'll definitely end up in emergency. But you take a couple of Panadol each morning, and that is the same theory behind exercise medicine dosage. So this year, my colleagues and I produced the guidelines for exercise medicine for cancer management. We published the first guidelines back in 2009. They were very conservative. In 2009, the general recommendation was that cancer patients should rest. The result, of course, was not that great. Patients were actually declining quite markedly. Many of them would then succumb to other diseases, in particular cardiovascular disease. And so our recommendation back in 2009 is just get off your butt, just get out and exercise, try and do some amount of exercise. But it was quite conservative because it didn't have the trials to actually show efficacy. Of course, 10 years later in 2019, we have literally hundreds of high-quality exercise oncology trials with a range of cancer patients. And we've now moved to a highly prioritised and targeted exercise recommendation. Now, we published this back in May in the Journal of Science and Medicine in Sport, supported by Exercise and Sports Science Australia. So what's our overall sort of recommendations here around the application of exercise as a medicine? Well, now we're recommending that exercise medicine be prescribed prior to therapy. So that is termed neoadjuvant. Adjuvant refers to a treatment which is given alongside the main treatment. Neoadjuvant means it's given before the main treatment. So now we're recommending that exercise medicine should be used prior to commencing chemotherapy, radiation therapy, and certainly prior to prostatectomy, surgery for prostate cancer. And there's a wide range of reasons why that's important. So, not the least of, it seems to help aid in coping with the diagnosis. When you are told you have cancer, as many of you have experienced, it's a very difficult time. Exercise suppresses the anxiety and reduces your risk of developing other mental health issues around that diagnosis. That's very important. Stress is a great feeder for cancer. When you are anxious, it creates changes within your body that actually promote the tumour to develop. So reducing your level of anxiety and depression is critically important. Exercise seems to help with that. Prepare you for treatment, physically and mentally. Prevent progression of the disease. There's good evidence that if you exercise, it will slow the progression of the disease while you prepare for therapy. Optimise body composition. That's very important. Again, unfortunately in Australia, around 67% of the male population is overweight or obese. That creates enormous issues in terms of surgery. And the surgeons report to us it's becoming increasingly difficult, even with robotic techniques, to operate on Australian men because of increasing body fat. So, what we're now doing, we've just completed a trial which was very effective, one of my PhD students, where in the 8 to 10 weeks leading up to prostatectomy, we managed to reduce overall body weight by around 12 kilograms. Now, that is a huge reduction in body fat in these patients, and the surgeons then report that the patients are much easier to operate on, they do better under anaesthesia, that the tissues are less inflamed, and we're seeing better post-surgical outcomes in those patients. So you can actually improve the body composition. You can also enhance other therapies that go on leading up to treatment as well. Quite often the patient will receive neoadjuvant radiation or chemotherapy to shrink the tumour. Exercise helps to reduce the side effects of that. We then have application of exercise in the adjuvant setting. So this is during receiving treatment. Most of our work has been conducted in androgen deprivation therapy because of the toxicities that are proving highly problematic with that. Our group and others have shown that appropriate targeted exercise can reduce or totally remove all of the side effects of androgen deprivation therapy. It also allows for optimal treatment and treatment doses. Our research and others have shown, for example, that under chemotherapy, patients who are exercising can tolerate higher dosages and have less likelihood of dose reduction because of side effects. So that enhances the chemotherapy treatment. I'll keep moving because I've lots to cover. And then, of course, post-treatment is where exercise medicine has mostly been applied. All the treatments are now completed. But the patient is now deconditioned, both physically, in terms of their structure, but also in terms of their function. And exercise is very important for improving physical function and structure and returning to a better quality of life. And most importantly, we now know that exercise reduces the risk of recurrence of disease as well. I'll skip over this one. Our original recommendation back in 2009 was, look, just get out and exercise. Do any physical activity, it doesn't matter, just get off the couch. That remains true, that's very important, but we can do a lot better than that. We can have targeted, precision exercise medicine. Now, for a cancer patient, as many of you realise, there's a lot going on. You've got appointments, there's issues around financial capability, all the other things that are going on. You may still be working, you've got family commitments, everything else going on. It is difficult to get time to get your exercise medicine. So what we're doing now is recommending to target those issues which are most likely to cause the greatest morbidity and mortality. And then targeting in on that. Not giving a generic exercise recommendation, but really targeting in. For example, if you're on ADT and you have a problem with developing osteoporosis, let's focus on that. Let's not worry about increasing cardiovascular fitness, aerobic fitness. We need to focus on what is going to cause the greatest difficulty for the patient. We focus on patient goals, their access and their financial capability to actually pay for the exercise medicine as well, and what the patient actually wants to get out of the program. Treatment enhancement is the next priority, and the last priority, to be honest, is general health and fitness. We have to target in on what's most crucial. Now, busy slide, apologise for this. These are the recommendations around aerobic and resistance exercise there. I won't go into too much detail of those, but again, the priority is depending on what is most important in terms of improving survival outcome for the patient. The aerobic exercise recommendation, it's probably around 20 minutes in duration per session. It can be either moderate intensity continuous that we talked about, but more and more we're applying high-intensity interval exercise. And the reason why is particularly patients experiencing a lot of fatigue, they tolerate that high-intensity intermittent training much better. Again, the resistance exercise is very, very important. Most patients should be pursuing this at least 2 sessions per week, preferably 3 to 4 resistance training sessions. Again, it's better to do a very small session of maybe only 20 minutes and do that 4 times over the week than do an hour on Monday and an hour on Thursday. Better to spread the exercise dosage over a number of days there. We also are very conscious of actually targeting the exercise medicine to the problems which are most likely going to either cause mortality or morbidity in the patient. So an example here is cachexia, very common problem in a lot of patients, particularly with advanced disease. This is loss of body mass. Now, the worst thing that patient can do is go out and do a lot of walking, but that may still be the recommendation. I'd say, oh, you need to exercise, go out and walk, okay? That only increases the energy difference, and so the patient will only lose weight faster. The recommendation for that patient should be targeted resistance training and supplementation to try and maintain muscle mass. The same for bone loss here. As we saw in my previous slide, our research has shown that certain exercise has no benefit in terms of bone loss. A lot of patients are told to swim. Swimming's a great exercise. I love it. Do it every Wednesday. Right? If bone loss is the problem due to, say, androgen deprivation therapy, swimming has no benefit whatsoever. You have to target the issue which is most significant. The presence of other chronic diseases. For example, if due to, again, androgen deprivation therapy, the cardiovascular risk of the patient is skyrocketing, you have to get a handle on that first. It doesn't matter that they've got prostate cancer or that they're overweight or that they're losing muscle mass if they're going to die of a heart attack. So you have to target what is most high priority there. Now, who should and shouldn't exercise? These are the absolute contraindications to exercise. All right? Recent change in resting ECG, ischemia, myocardial infarct within 2 days. Unstable angina, I won't go through them all. Aortic stenosis, acute myocarditis or pericarditis, okay? Or acute infections. If you don't have one of those, you're good to go. All right? No excuses. Now, a lot of the clinicians that haven't worked with us as much before, they say, oh, this is great. We really like this, Rob. I'll send you my really healthy patients because they'll be able to do the exercise. Look, we'd love to see those patients, but we'd rather see the patients that aren't doing so well because they are the ones with which exercise will be the most benefit. They're the ones we need to actually work with. So if you haven't got one of these, you have no excuse. And I'll post that probably less than 1% of the audience would have any of those. But it all depends on the patient, the setting and the supervision. Now, of course, you're not going to get a patient with advanced metastatic prostate cancer who's 75 years of age, who's had a history of cardiovascular disease, and send them down to the local gym. Or send them to go home in their garage, buy some weights and have a crack at it. All right? You don't do that because it's a very dangerous and uncontrolled situation. So the setting's very important, from the park or home, community centre, fitness centre, right up to an exercise clinic or a hospital. In terms of the supervision, self-management is fine for a patient who is relatively healthy and has low risk. But then we need to, certain patients need to go and see a fitness professional or allied health professional. And certainly those that have advanced disease and serious comorbidities, they need to work with an exercise physiologist with oncology training. So how do you find one of those? Well, accredited exercise physiologists, they are the most appropriate allied health professional to deal with chronic disease and exercise assessment and prescription. They're accredited by Exercise Sports Science Australia. They are covered under Medicare. And to find one, you can go to a website here called Find an AEP. You can put in your postcode and how far away you want to go, travel, 20 kilometres in this case. You can put in a specialty of cancer and it will show you a list of those AEPs within your area that have specialist training and experience working with cancer. So thank you so much. I want to thank the PCFA in particular for the opportunity. I love talking to patient groups in particular. It's my favourite. Talking to other scientific boffins and clinicians is always a bit boring. So I love to come and talk to groups like this. So thank you so much. Thank you.